Hi, I'm Dr. Chantel Thornton. Now that you've been booked in for surgery, I'll be sending you occasional brief videos, information and tasks before and after your operation to ensure that you're well informed about the operation and to make sure you have the best outcome from surgery. So please make sure you take note of any SMSs, watch the videos and complete the tasks I send you. I will start now by going over a brief summary of the operation you've chosen to have. You are having a subcutaneous mastectomy. A subcutaneous mastectomy is performed with an immediate breast reconstruction. The entire breast will be removed and the entire skin envelope, including the nipple and areolar complex, will remain intact. There are different styles of reconstructive options and the plastic surgeon will do an immediate breast reconstruction at the time of surgery. A small tissue expander, which is like a bag of fluid, or an implant will be placed under the pectoralis muscle. The plastic surgeon can also take tissue from elsewhere in the body to make you a new breast. The breast will not look the same after the operation, but you will have fullness in the bra and we'll do our very best to minimise scars and make the breast look as symmetrical as possible. The goal is obviously to keep the nipple and areolar complex. However, we do take small scrapings behind the nipple at the time of surgery, which are sent off separately to the pathologist. If when the final pathology is obtained, there are cancer cells in these scrapings, the nipple will need to be removed at a later date. There is also the potential chance that the nipple may die back after the operation and therefore would need to be removed at a later date. You are also having an axillary lymph node dissection. This is a process whereby I take out all of the lymph nodes from under your armpit. A common question is, how many lymph nodes will I need taken out? Some patients will have 10, some will have 20. The most I've ever taken out is 45. But I actually never know until I begin the operation because everyone's anatomy is different. Some patients report that the operation can be quite painful. The pain generally comes from the armpit and not the breast, but the pain will rapidly improve and we'll make sure we're on top of your pain relief. After the operation, you should be able to do your usual activities and we ask that you start moving your arm early day one after the operation. We'll get a physiotherapist to see you to help you with this. You will have a drain tube inserted into the axilla post-operatively. As with any surgery, there are some risks involved. These include risks associated with the anaesthetic and risks associated with the operation itself. Anaesthetic risks include a chance of a DVT, which is a blood clot in the legs, or a pulmonary embolus, a blood clot travelling to the lungs, stroke or heart attack. These are very unlikely and we do many things to reduce the likelihood of these occurring. Your anaesthetist will discuss these risks with you further. Risks associated with the operation itself include general risks that occur any time after an incision is made on the body. These include infection, bleeding, or hematoma, which is a collection of blood, and scarring. There are also risks specific to mastectomy, such as seroma, which is a collection of fluid under the skin. This can be easily dealt with post-operatively. There is also a syndrome known as phantom breast pain, whereby there is a sensation that the breast still exists after it has been removed. This is an uncommon situation. There are also some risks specific to axillary lymph node dissection. These include a risk of nerve damage and lymphedema. There are small nerves under the armpit that need to occasionally be sacrificed or cut to get the lymph nodes out. This can cause a feeling of tingling, pins and needles, or numbness in the side of the arm or the inner part of the chest wall. There are some also big nerves and vessels in the armpit which are particularly important to shoulder movement, and in general these are not damaged by this operation. Patients who do have these nerves damaged will usually not notice this during their usual daily activities. There is a small chance of swelling of the arm associated with this operation, which is commonly known as lymphedema. It has been quoted to occur in approximately 30% of patients. The important thing to know is that most ladies in today's surgical techniques will not have lymphedema of the arm. Lymphedema associated with surgery many years ago was due to the fact that surgeons would remove lymph nodes that drained specifically to the arm. With the new techniques used with axillary lymph node dissection, surgeons will not be removing lymph nodes that drain to your arm, and therefore I find that lymphedema is actually quite uncommon in my patients. As always, if you have any further questions, please don't hesitate to contact me or the breast care nurse.